Hello, everyone, and good afternoon. Thank you for joining today's presentation brought to you by the Sudden Arrhythmic Death Syndromes Foundation with support from Invitae titled Sports Safety for Patients with Inherited Arrhythmias and Cardiomyopathies. Today's presenter is Dr. Susan Etheridge, who is the Director of Pediatric Cardiology Fellowship and Residency Program at the University of Utah School of Medicine and Primary Children's Medical Center in Salt Lake City, Utah. Dr. Etheridge is also the Board Vice President of the SADS Foundation. Before Dr. Etheridge begins today, I would like to briefly mention that everyone can submit questions for Dr. Etheridge anytime during the presentation using the questions pane of your GoToWebinar control panel. Dr. Etheridge will address these during today's Q&A session after her presentation. Also, today's webinar will be recorded and available for later viewing on both the SADS Foundation and the Invitae websites. Dr. Etheridge, we thank you for your participation today and have been really looking forward to it. Thank you.
Thank you, and thank you all for joining. I am coming to you from Salt Lake City, and I'm going to talk about inherited genetic cardiomyopathies and channelopathies. Let's get off the couch. So my objectives during this period are to explore why sports are important, possibly now more than ever, to understand a little bit about the basics of hypertrophic cardiomyopathy, arrhythmogenic cardiomyopathy, and a few, but not all of the channelopathies, and to review risk of sports and cardiomyopathies and channelopathies, and then outline some of the concepts of shared decision-making and explore ways patients with cardiomyopathies and channelopathies might be able to play safely. Certainly, these high-profile sudden deaths have raised awareness of the fact that ostensibly very healthy, athletic people can die, and they can actually die while playing sports. It's kind of interesting. There's a little bit of difference. There are conditions where events only or usually occur with sports. There are conditions where sports make the disease worse, conditions where specific sports increase risk, but not all sports. And then there are conditions that we'll talk about where sports can be made safe. Through my talk, and possibly every time you look at a journal, you see these pie graphs looking at what patients die suddenly during sports, and all the graphs are different with different sized pies, and that depends on the age of the patient, the geographic location, and whether they're actually athletes who are dying suddenly or people dying suddenly during the sports activity. But let's take a step back and think about what are the causes of sudden death, or excuse me, of death in patients, young patients aged 1 to 21. And you can see from this graph from the CDC that it's really injury, homicide, and suicide that top the list, with cardiac and sudden cardiac death quite low, although high profile and emotionally charged. And I want you to remember that any individual with hypertrophic cardiomyopathy who's playing basketball likely has a lower risk of death compared to an individual with a normal heart who climbs mountains. And certainly our society doesn't prohibit these high-risk sports for our patients. So I want to talk a little bit about what's wrong with the couch. I think it's that we're struggling right now with physical inactivity that's increased in our pediatric patients in the last couple of decades, and that there's this growing childhood obesity epidemic or exercise deficit disorder. This is made very clear by these graphs from the National Health and Nutrition Examination, where in 1960, 4% of our children aged 6 to 11 were obese. That quadrupled in 2002 to 16, and it's estimated that 42% of our pediatric patients will be obese or overweight by 2030. So this prevalence of obesity will increase by 130% over the next 2 decades. Not only is it increasing over time, it's increasing as these patients age. And this seems to be somewhat of a problem located in the United States more than in the world at large. And interestingly, 80% of our obese children will become obese adults. So what is the exercise deficit disorder? Well, obesity is the most preventable cause of death in the United States right now. That unhealthy weight gain due to poor diet and lack of exercise is thought to be responsible for over 300,000 deaths per year, to a cost of about $100 billion. So exercise restrictions, when we give them, we should give them cautiously and based on solid knowledge. Because there are things good things that sports can do. Obviously, they can help control weight, but there are also data to suggest that they may prevent suicide, enhance and protect brain function, protect against adolescent substance abuse, and foster positive youth. So really, we have to think about, is it really okay to deny these benefits to adolescents and children with heart conditions? So let's look at the causes of sudden death. There's some data about sudden death. So one of the largest and most recent studies looking at sudden death in the young is out of this group from Australia and these groups from Australia and New Zealand, and they identified 490 cases of sudden death in young people under age 35. Interestingly, you can see that most of these deaths actually occurred during sleep or rest rather than exercise or after exercise. Of these 490 cases, about 40% were autopsy negative sudden death. You can see that ARVC and hypertrophic cardiomyopathy did factor into this, but this group, the unexplained or autopsy negative sudden death, was the largest. An autopsy negative sudden death is likely due to an inherited abnormality of a cardiac ion channel and how it works. Most of these are inherited in an autosomal dominant manner, and we're not going to talk about all of them, but we are going to talk about a few. Most commonly, or the most common channelopathy, is long QT syndrome. Oops, sorry. This slide isn't working very well. This is the most common. It occurs in about 1 in 2,000 to 1 in 2,500 people. The symptoms are syncope and sudden death or seizures. And it's a difficult disease to treat or to think about because of the variable expressivity and low penetrance. This is just an ECG showing a patient with long QT with pretty profound repolarization abnormalities to the extent not only of QT prolongation, but of T-wave alternans. This is a monogenic disease in most people, so about 75% have a single amino acid mutation that causes the disease, as shown here, where a valine is replaced by a methionine in this position. But even when we think about long QT syndrome, not all of this disease is the same. You can see that there are type-specific triggers in long QT syndrome, and exercise seems to factor largely in LQT type 1. And interesting, it's not all exercise, and we think that swimming is a particularly problematic sport for this population, possibly because it combines exertion, voluntary apnea, cold water exposure, and face immersion. You can get increased sympathetic and parasympathetic activity through this dive reflex, which can precipitate PVCs, which is a trigger for arrhythmia. We know that cold water face immersion lengthens the QT and can cause T-wave alternans. And when you combine adrenaline with long QT syndrome type 1, you do notice a paradoxical QT prolongation. And what might just be a faint on dry land can become a drowning or a near drowning in the water. And there are certainly a lot of articles that outline swimming as a particular risk factor. And in fact, swimming events are 10 times more likely in long QT1 compared to long QT type 2. So how do we make sports safe in this population? Well, I think, and we'll talk at the end about shared decision-making, where the physician, a well-informed patient and family, and a coach agree that this is an okay thing for the child, that there's an emergency action plan in place, an AED is available. We talk a lot about hydration in this population, and then one of the newer things that we've understood is that of increase in core body temperature or overheating can lengthen the QT interval and potentially provoke arrhythmia. We need to avoid a low potassium, and then these patients need to be compliant with their medications and with clinical follow-up. Shifting gears slightly to another channelopathy, catecholaminergic polymorphic ventricular tachycardia. This is a potentially lethal genetic arrhythmia, possibly responsible for about 15% of autopsy negative sudden death. And unfortunately, sudden death can be the first symptom in about a third. Untreated, the mortality is thought to approach 30% by age 40. This is an interesting arrhythmia problem characterized by bidirectional ventricular tachycardia, as shown on this electrocardiogram, where there's a 180-degree beat-to-beat QRS rotation. This is highly suggestive of CPVT, although it is not always observed. Interestingly, this bidirectional ventricular tachycardia is often quite well tolerated because these patients are often young and have a normal heart, but unfortunately in some, it can degenerate into ventricular fibrillation. We did a fairly sizable study of CPVT in pediatric patients, looked at 226 children in this multi-center study, and you can see that most of their events are exertional or during emotional times. And exercise testing remains the most important diagnostics tool and can also help us assess the adequacy of our therapy. So when these patients get on the treadmill, they're in sinus rhythm. As they start to exercise, they develop just ectopy, which can become bidirectional ectopy, and then bidirectional tachycardia, which wasn't shown on the slide. Slides aren't coming across perfectly, I'm sorry to say. There are not a lot of data in sports participation in this population, but one of the articles comes from the Mayo Clinic where they looked at, this is supposed to say 63 athletes, of which about 20 continued to be athletes. And when the athletes versus the non-athletes were compared, their survival curves, event-free survival curves, were not really different. And both groups had an 80% event-free survival during 5 years of follow-up, suggesting that sports can be made somewhat safe in this population. There are a lot of more recent data concerning the use of ICDs and sports. Theoretically, there was a concern that there was an increased risk of ventricular arrhythmias, that the ICD would be unable to terminate the arrhythmia, that there'd be a risk of injury during syncope or from a shock or damage to the system. And a fairly sizable study looking at patients, young patients and old patients with ICDs, was undertaken by Rachel Lambert. This is the population that was characterized, and you can see long QT syndrome and hypertrophic cardiomyopathy did factor largely in this registry. Now, shocks did occur in this population. They weren't rare, but there were no injuries or fatalities, and there was no failure to defibrillate. And many of the patients who had a shock during their sports returned to the sports activity. So what are the causes of sudden death in young athletes? Other causes, and one is that we're going to talk about is hypertrophic cardiomyopathy. This is a pie graph from Barry Marin looking at the portion made up of hypertrophic cardiomyopathy. I think you probably all know that this is due to mutations in the genes that encode for the cardiac sarcomere contractile proteins, and in these patients we see left ventricular hypertrophy without pressure overload. This is made up of myocardial disarray, where there's disorganized heart muscle cells that predispose to arrhythmias, and the arrhythmias are ventricular tachycardia, as shown here, or ventricular fibrillation. This is the most common genetic cardiomyopathy, occurring in about 1 in 500 people, but has variable severity. Some people have a normal lifespan, and others have a high symptom burden. The prognosis is favorable in low-risk patients, and the annual mortality less than 1% in the last 40 years. But sports remain feared, and patients with hypertrophic cardiomyopathy are often restricted, even though most deaths are not during exercise. Interestingly, in 2015, the sports recommendations for patients with hypertrophic cardiomyopathy were reinvestigated, and they remained essentially unchanged from those brought up in 2005. And sports, according to these new Bethesda guidelines, remain a modifiable risk factor. As a result of their disease, hypertrophic cardiomyopathy patients remain less active than their peers. And actually, patients are known to reduce their activities after their diagnosis. The guidelines continue to recommend restricting competitive sports to low static and low dynamic. And that's this group down here in the low corner, which really constitutes bowling, cricket, golf, etc. Their recommendations are against vigorous activity and even recreational sports. And this is based on expert opinion with not a great deal of data. So there are some data that looked at physical activity and other health behaviors in adults with hypertrophic cardiomyopathy, and adults with this disease reported significantly less alcohol and tobacco use, which was good, but also reported less time engaged in physical activity, and their body mass index was greater in the hypertroph cohort than their controls. And they reported that exercise restrictions negatively affected their emotional well-being. So there was a noted relation of inactivity, obesity, and cardiovascular mortality that might be exaggerated in patients with hypertrophic cardiomyopathy, because it's easier just to say no sports. But there are some more recent data that say we might be able to be more liberal. Do sports in hypertrophic cardiomyopathy trigger sudden death, exacerbate or accelerate adverse remodeling? These are the questions we need to ask. The guidelines, as I said, have remained essentially unchanged for more than a decade. And there's really no evidence for or against change until now. This is a study from Sarah Saberi looking at the effects of moderate intensity exercise training on peak oxygen consumption in patients with hypertrophic cardiomyopathy. The hypothesis of the study was that moderate intensity aerobic exercise would improve exercise capacity among hypertrophic cardiomyopathy patients without exacerbating the disease or increasing arrhythmic events. They had adult patients, 18 to 80, that were randomized to 16 weeks of moderate intensity exercise or just their usual activities. And moderate intensity exercise was compared with usual activity and was noted to result in a significant increase in exercise capacity without sustained ventricular arrhythmias, sudden cardiac arrest, appropriate ICD shock, or death. This is support for moderate intensity exercise, improving exercise capacity in patients with hypertrophic cardiomyopathy and doing it safely. And what about vigorous exercise? Well, this article came out of Norway, where they do exercise vigorously, and was published in 2018, looking at the relationship between a lifetime of vigorous exercise and cardiac morphology and function in hypertrophic cardiomyopathy. So they had 274 hypertrophic cardiomyopathy patients and their gene-positive family members. Before enrollment began, there had been 14 deaths, 6 probably from hypertrophic cardiomyopathy and none with exercise. They had 121 patients with the disease, manifesting the disease, and 66 who were genotype positive but LVH negative family members. And what they did was they completed a physical activity questionnaire detailing their history of exercise from elementary school to the present or to age 60. The median age was about 50. They median lifetime vigorous exercise over 1,600 hours. 25% reported no history of vigorous exercise. 39% defined themselves as athletic, and 37% were still actively engaged in vigorous exercise at the study inclusion. So despite recommendations against exercise, patients with hypertrophic cardiomyopathy are still exercising. And the good news from this study was that lifetime vigorous exercise correlated with improved stroke volume. That compared to non-athletes, the hypertrophic cardiomyopathic athletes had better diastolic function, but no difference in left ventricular hypertrophy, wall strain, ejection fraction, or the amount of delayed enhancement on MRI when these guys were compared to the non-athletes. So a lifetime of vigorous exercise was not associated with unfavorable or accelerated cardiac remodeling. Possibly it was beneficial with effects on left ventricular volumes and improved diastolic function. There was no difference in the age at first arrhythmic event between the athletes and the non-athletes based on this Kaplan-Meier curve. So being an athlete was not a marker of ventricular arrhythmias, and in their data, there's no signal for harm here. So right now we are in the middle of processing the data from an NIH-funded prospective observational study where we looked at how much are patients with hypertrophic cardiomyopathy exercising, and this is adults and children, exploring the effect of activity on their health and their quality of life, because we think data are mounting that exercise can be made safe in hypertrophic cardiomyopathy. But now for something slightly different. Arrhythmogenic cardiomyopathy, this is a genetically determined disruption of the intercalated disc. So defective cell adhesion proteins of the desmosome, and this affects the gap junction. Exercise results in stretching of the right ventricle. This myocardial wall stress results in higher tension on cell-to-cell adherences, so cells will pull apart. This results in inflammation and cell death, and the damaged myocardium is replaced by fibrofatty scar, and this predisposes to ventricular arrhythmias, wall thinning, and right ventricular dysfunction. Sudden death can occur during sports or because of endurance sports in this population of patients. There are data that arrhythmogenic right ventricular cardiomyopathy, what is now called arrhythmogenic cardiomyopathy, and elite athletics probably don't go well together, that there's a 2 to 5-fold higher risk of dying of ARV, D, or C compared with non-athletes. Elite athletes present earlier, that if you continue your high level of exercise after given this diagnosis, that you had an increased likelihood of ventricular fibrillation or ventricular tachycardia compared with those who reduced their activities. And the more hours of exercise you perform, the more your disease will manifest. Unlike hypertrophic cardiomyopathy, there are Kaplan-Meier curves in this population that suggest that athletes do more poorly from an arrhythmia standpoint and from a heart failure standpoint. And there is here a signal for harm. But encouragingly, if you compare, in this study, Ruwald compared those who were inactive to those who were performing recreational activities and actually found no difference in this population. Certainly those competitive athletes or vigorous exercisers presented earlier and were more likely to develop ventricular arrhythmias, heart failure, and death. So there is some good news that recreational sports are not really associated with earlier presentation or increased risk of arrhythmias or death compared to the inactive patients. So why is this? Well, it's thought that the right ventricular wall stress at peak exercise in athletes increases by 170% versus only 23% in the left ventricle. This is a disease of the desmosomes. Desmosomes provide the intracellular integrity, and increased stress on the right ventricle results in breakdown of the desmosomes with that fibrofatty replacement. Endurance athletes can have myocyte uncoupling at this defective desmosome, resulting in inflammation, fat, and electrical uncoupling, and unfortunately heart failure and arrhythmias. So the sports recommendations for ARVC are you need to outline the risk of sports and really go through these data with your patients so they understand it quite completely. Talk about disease progression and arrhythmia risk. Elite athletics are discouraged, but recreational activities are allowed. So exercise in moderation and discourage a sedentary lifestyle. So how do we use these data all to talk about patient-centered care? Patient-centered care really balances quality of life and the patient's health and safety. It's changing over the years. Clinician-patient relationships remain the cornerstone of care and are often long-lasting, but there are more and different therapies that are now available, and patients are living longer, and diseases thus are longer lasting and more chronic. Choices require value judgments. Patients now, I feel empowered to ask questions and express their opinions, and ultimately I think this will result in better health outcomes. There has been a decrease in the power asymmetry, increased patient information, autonomy, and control are occurring about the decisions that affect their health and well-being. So these decisions involve the patient, the family, the provider. The provider describes the different approaches. The patient and the family are now armed with appropriate and full information so they can share their preferences about treatment, and all parties share responsibility for the decisions reached. Patients and families become allies in designing and implementing and evaluating care. And clinicians relinquish some of their paternalistic authoritarian role and become effective coaches and care partners. So just for an example about shared decision-making in cardiomyopathy and playing safe. So this is a newly diagnosed patient with hypertrophic cardiomyopathy. The patient's values will guide all clinical decisions. So the patients are encouraged to tell the clinicians about what they care about. So tell me about you. What sports do you play? How important are sports to you? How hard do you play? And what are your other pastimes? Inform the patient about and the family about hypertrophic cardiomyopathy, explaining their role in decision-making, arming them with knowledge and the tools to understand the options and the consequences of their decisions. Explain the disease and the treatment, outline the risk of sports in their condition, but the benefits of sports in general, and outline what we know and also what we don't know about risk. Shift the focus away from the disease to the patient. You are not just a hypertroph, but a person who has hypertrophic cardiomyopathy. You're different from other patients with hypertrophic cardiomyopathy and have different values. So in shared decision making, we have shared consequences. The patients, the parents, the clinicians, even the coaches should try to be on the same page. The patients have to be compliant with their clinic visits, their medications, their restrictions, and their treatment. Sports equipment should include AED availability, hydration, avoiding overheating, and having an emergency action plan in place. So finally, clinicians must stop playing it safe by just saying, no, that's so easy, and start encouraging self-play, or playing safe by our patients. Thank you. And now I'll take questions.
Great, thank you so much, Dr. Etheridge. So I'll remind everyone that in the audience that you can submit questions using the question pane. Just type them in and hit submit. While those questions are coming in, I'll ask one of my own here. And this is a bit of almost the other side of the coin kind of question. So today you discussed sports participation for those diagnosed with inherited arrhythmias and cardiomyopathies, but I'm curious if you have any thoughts to share on the systematic screening of athletes to possibly identify underlying but undiagnosed heart conditions prior to actually having an event on the playing field.
Oh, that's such a difficult question. You mean ECG screening? Or
yes, exactly.
I think at present I advocate screening by clinical history, family history, and clinical and examination. Not sure we're really quite ready yet to undertake ECG screening or higher testing screening in the United States. I don't know that we can handle the burden financially for this, but certainly if anything becomes a red flag in the diagnosis in the history or the family history, then you would go on with more further testing. So I think it's really our primary practitioners now who are the front lines for this, the pediatricians, the internists who see these patients a lot more frequently and can ask the important questions.
Great, thank you. Are there any instances where patients should keep their heart rate below a certain threshold while exercising?
That is also an interesting question. And we personally, when we see our patients with CPVT and with long QT syndrome, we exercise them fairly routinely, especially those that are athletes, trying to keep their heart rates under 150 for the littler children and 140 for the older adolescents and adults. One, it tells us that they're fairly compliant with their beta blockers, or at least they have been over the last few days, and it lets us know that their beta blocker dose is adequate. As far as Apple Watches, etc. But I use 150 for kiddos and 140 for adults.
Great, thank you. So not really exercise, but what about amusement park rides like roller coasters? Are they safe for SADS kids?
Not all SADS kids, and I certainly worry about this. One, I think when you're exercising, you're in control. You can stop if you feel bad. You can, you're in control. When you're on one of those rides, you're not any longer in control. Some teenager possibly not paying any attention to you is actually in control. So if you should have trouble, it'd be pretty hard to get someone's attention. You also can't be allowed to lie down. So what might be a pre-syncopal event would become potentially a syncopal event, and you're still seated. So I'm pretty cautious about rides. I outline, which ones I think that are okay and which ones aren't. And obviously this is very patient specific. Some kids don't find it scary at all, and others find it terrifying. I think there are certain amusement parks where things are more sophisticated and done a little bit more safe versus just the fair grounds locally. And I really worry about haunted houses, especially in kids who startle is a problem, like the long QT2 patients. But good question. We have seen a number of events that have occurred. In fact, I had an event last week. A girl got an appropriate shock from an amusement park ride.
Oh, wow. Dr. Newton-Shea asked if there are any data to suggest that exercise contributes to disease progression in ARVC with left ventricular predominant disease.
That's a very good question. I don't know the answer to it, actually. I would suspect it would be milder than with right ventricles because the left ventricle tolerates stress so much better, but I don't know those data. The only data I know are on truly traditional ARVC.
All right. One of our audience asked if you were wondering whether you tell your patients with hypertrophic cardiomyopathy who already have an ICD, do you allow them to do everything that they wish, or do you still recommend modifications?
I talk about what they like and what they want to do, and I try to encourage them to do more aerobic sports rather than sports that involve heavy weightlifting and muscle training. I'm not a huge fan of football. I think it's bad for your brain as well as for your heart. So I try to discourage that. But I have a number of hypertrophs that are playing soccer, basketball, tennis. I try to steer them, and usually you can get their parents on board with that, but not always. Certainly patients within the Hypertrophic Cardiomyopathy Registry did play football, and relatively safely.
Perfect. A couple of the audience have asked questions along a similar thread. For instance, like where can they find a comprehensive list of moderate versus vigorous activities that they can discuss with their patients? Where can they find the latest recommendations for exercise with long QT1?
So the latest recommendations are from that Bethesda update from 2015. It's published in the ACC, in JACC, and I think it's also published in CIRC, and it's certainly online. The LQT recommendations in that document are quite good and much less restrictive than they had been in the past. So definitely I would use those. That document is many, many parts. The first part outlines that box diagram that I showed you where the exercise is all outlined. And then there's a section for the channelopathies. There's also a section for hypertrophic cardiomyopathy. But as I said in my talk, that has not changed much since 2005. And I don't think it's really kept up with the literature that suggests that sports can be made safe in the hypertrophic cardiomyopathy population. So I would say stay tuned for what we are going to come up with from the NIH Live HCM study, and we should have those data within the next couple of years, I would think, because we have stopped enrollment and started analyzing data now for that population. And it was big.
Oh, that's wonderful. Thank you. Dr. Jorge McCormick asked regarding HCM, he says not all patients are equally severe. Do you have any comments regarding risk stratification, severe versus mild, obstructive versus non-obstructive, and recommendations for sports depending upon the severity?
That's a very good question. So, we certainly think a lot about severity in terms of who needs an ICD and who doesn't. And I do tend to be a little bit more restrictive in patients with left ventricular outflow tract obstruction. And I'll exercise everybody that has hypertrophic cardiomyopathy to look for LV outflow tract obstruction that worsens with sports. And I've had some kids go from nearly nothing to over 100. And then in my mind, that qualifies them for surgery for LV outflow tract obstruction. Certainly we feel better about allowing the patients who are genotype positive but phenotype negative to participate in sports. I think it's encouraging that we don't think sports are going to make them become a phenotype positive patient. And I would do everything I could to at least allow them to be recreationally active. And even in those with some outflow tract obstruction, I think it's so much. I don't think there are a lot of data to suggest that people that we know have hypertrophic cardiomyopathy are dying during their sports events. Great. Hi, Jorge.
The next one is a very, very specific question. Does the, and maybe we can broaden this one out, but I'll read it as written. Does the NHL or other hockey organizations reject individuals with HCM?
Probably. They don't. Yeah. They don't want the liability. I think most colleges still don't honor if you get a sports scholarship. I think many colleges would deny you and take your scholarship away once you were identified as having HCM. I really have hopes that this is going to change in the next decade as more and more data become available. But for right now, I think that the NHL and the Football League would say no.
Could you comment a little bit on dilated cardiomyopathy in sports?
Oh goodness, that's not a population that I typically care for that much because they are pediatric kids with dilated cardiomyopathy don't typically have a lot of an arrhythmia burden or phenotype, and I'm an electrophysiologist. I don't know of great data about sports and dilated cardiomyopathy. If you look at that article from the Simsarian groups out of New Zealand and Australia, it was in there, but it didn't represent a significant portion of that sudden death population. I think as you get older with DCM that your arrhythmia burden increases and your risk of sudden death probably goes up, but I'm not certain that that's really limited to sports. I think it could be just globally. I'm not sure that answers your question. It's as good as I have.
That's helpful. Among the exercises that are considered, vigorous versus non-vigorous and are okay for ARVC patients, where does weightlifting fit in?
Ooh, I would try to discourage that, especially heavy weightlifting. I would say that they could do what I allow my significant congenital heart disease patients to do, which is frequent reps of a light weight. So if you can lift it 15 times and do 3 sets of that without holding your breath and bearing down and raising your blood pressure, that probably would be okay. Where I've seen most ARVC give us trouble is the rowers, the skiers, and the cyclists. That real aerobic pushing themselves group of patients.
Well, we've gotten through all of the audience questions, and I haven't seen any come in the last couple of minutes, so I think those are done now. I think we're at the end of our time together then, and I would like to thank all of the attendees for their participation today and submitting questions, and especially you, Dr. Etheridge, for sharing all your insights with us.
Thank you. Thank you for having me.
Okay, and just a reminder, everyone, this webinar will be recorded and will be available on both the SADS Foundation and the NVT websites. Great, and we'll just go ahead and fit one last question in if you're still there.
Sure,
myocarditis and the recommendations there. Do you have any comments?
While they're actively inflamed, no, I would say no sports. Routine activities would be fine, walking, but once the disease seems to have run its course, then I would think that their risk would go down. Obviously, you'd be following that patient in clinic for arrhythmias and watching them for the development of dilated cardiomyopathy, and then they become that patient rather than a myocarditis patient.
Great. Thank you so much, Dr. Etheridge. It was really enjoyable. Thank you so much for your presentation today.